Hello and welcome to my channel. In this lecture we will start discussing the hand. It's the osteology and fascia. So let's begin. The hand, in anatomy, it's subdivided into three parts. The wrist, which is the carpus, and the metacarpus and the digits. Okay, carpus, metacarpus, and digits. We have, of course, five digits: thumb lateral, then the index, middle ring, and little fingers, or we start counting from the thumb being the first. Anterior surface is a palm, and the dorsum is the dorsum of hand. Abduction and adduction of fingers is in respect to the long axis of the third finger, which is the middle finger. Remember, in the foot, it was the second toe, but here it's the third finger or the middle finger. Long axis of thumb rotated 90 degrees to the rest of digits, okay, because of its position. The three groups of bones in the hand: we have 8 carpal bones, the wrist bones, 5 metacarpal bones, 1 to 5, 1, 2, 3, 4, 5, and phalanges. Thumb has 2 phalanges and the rest have 3 phalanges. The phalanges are proximal, middle, and distal. Here are proximal and distal only. The carpal bones arranged in 2 rows. See, this is a row, this is another row, this is the proximal row, this is the distal row. Each row contains 4 bones. The proximal row from lateral to medial, the scaphoid, or in all books it's navicular, the scaphoid, lunate, triquetral, and pisiform. The scaphoid being a boat-shaped, and the lunate crescentic in shape. Triquetrum is 3-sided, and the pisiform is P-shaped. Okay, the pisiform is a sesamoid bone in the tendon of flexor carpi ulnaris and articulates with the anterior surface of the triquetrum. The scaphoid has a tubercle directed anteriorly. You can see it here. Palmar surface on the lateral palmar surface of the bone. Okay, the distal row from lateral to medial is trapezium, irregular in shape and 4-sided, trapezoid, 4-sided, capitate that has a head, and hamate that has a hook. Okay, so scaphoid, lunate, triquetral, and pisiform, trapezium, trapezoid, capitate, hamate. There's a phrase for that: she looks too pretty, try to catch her. Okay, this is how they used to learn them by heart. The trapezium articulates with the metacarpal of the thumb. Here, trapezium with the metacarpal of the thumb has a tubercle on the palmar surface. Largest metacarpal bone is the capitate, articulates with the metacarpal of the third metacarpal base. The hamate has a hook that projects anteriorly. You can see it here. And the carpal bones articulate with each other at intercarpal joints. Distal row articulates with the metacarpals at the carpo-metacarpal joints. All are plain synovial joints with and share their synovial cavity. The first carpo-metacarpal bone is synovial of the saddle type, has more movement than the others to give free movement for the thumb. Okay, the carpal arch, the way they articulate together and the ligaments hold them together, they form an arch formed by the carpal bones. Lateral side formed by the scaphoid and trapezium, and the medial side formed by the pisiform and the hook of the hamate. This arch is bridged by the flexor retinaculum to turn this concavity into the carpal tunnel. Okay, the carpal tunnel. The metacarpal bones, each for a digit, of course, and they have a proximal base and the shaft and the distal head. Proximal base, shaft, and distal head. The base articulate with each other as well as with the carpal bones, and the heads articulate with the phalanges, the bases of the phalanges at the metacarpophalangeal joints, and these articulations, the heads of the metacarpals that form the knuckles when we make a fist with the hand. The thumb has two phalanges, proximal and distal. The rest have three, proximal, middle, and distal. And each phalanx has a base, a shaft, and a head. Bases articulate with the heads of the metacarpals as the metacarpophalangeal joints that forms the knuckles as mentioned earlier. Now the wrist joint, the radiocarpal joint, this joint, synovial joint of the ellipsoid type, it's biaxial joint, between distal end of the radius and the articular disc we talked about that isolates the ulna from the joint, okay, with the scaphoid, lunate, and triquetral comes in full adduction, triquetral bone in full adduction. So scaphoid, lunate, and triquetrium. Movements, adduction, abduction, flexion, and extension. And the sum of all these movements is circumduction, but it's not an individual movement. Radial styloid process extends more than the ulnar styloid process laterally, so this limits abduction more than adduction. So adduction is to a greater degree than abduction at the wrist joint. The capsule is around the articular surfaces and enforced by ligaments. It's thin posterior. Now the ligaments of the wrist, we have the palmar radiocarpal ligament from the radius to all the carpal bones. This ligament, it increases the stability and ensures the hand follows the arm during supination. We have the dorsal radiocarpal ligament, the same ligament but on the back, and it's also for stability and makes sure that the hand follows the forearm during pronation. We have a palmar ulnocarpal ligament, as you can see here. We have an ulnar collateral ligament and a radial collateral ligaments. This is the sum of all the ligaments of the wrist joint. Relations of the wrist, we have anterior and posterior relations. From lateral to medial, the anterior relations are abductor pollicis longus, extensor pollicis brevis on the lateral surface, then the superficial branch of radial nerve, then the radial artery, as you can see here, then the flexor carpi radialis, flexor pollicis longus, the median nerve covered by the palmaris longus tendon, okay, then the flexor digitorum superficialis, the ulnar vessels, and the ulnar nerve, and flexor carpi ulnaris. These are the anterior relations of the wrist, and do not make the mistake that consider the anterior relations of the wrist are the contents of the carpal tunnel. No, carpal tunnel is further anterior, further distal in the hand. We are talking about relations at the wrist, and that's one thing. And the other thing, the ulnar vessels and nerve do not enter the carpal tunnel, so they are not contents. Okay, the posterior relations of the wrist joint are the same as the compartments under the extensor retinaculum. This is the extensor retinaculum. From lateral to medial, they are abductor pollicis longus, extensor pollicis brevis in one sheath, extensor carpi radialis longus and brevis in synovial sheath, extensor pollicis longus in its own sheath, okay, extensor digitorum and extensor indicis in one sheath, extensor digiti minimi in a separate sheath behind the inferior radial ulnar joint, and at last the extensor carpi ulnaris, grooving the back of the styloid process of the ulna. Okay, these are the relations of the wrist joint. The blood supply by the anterior interosseous artery, the palmar and dorsal carpal arches by the radial and ulnar arteries, and the deep palmar arch by the radial artery. The nerve supply of the joint is anterior and posterior interosseous nerves. Okay. Carpal joints, they share a common synovial cavity, a capsule enforced by numerous palmar and dorsal ligaments. The carpo-metacarpal joints between the bases of the metacarpals and the carpal bones. The first carpo-metacarpal joint is synovial of the saddle type, gives free movement for the thumb as adduction, abduction, flexion, extension, rotation or opposition, and circumduction. Rest of joints allow only gliding movement between them. Okay, now for adduction of the thumb, bring it in the same plane of the palm. Abduction, again away from the palm but in the same plane. Do not raise your thumb. Adduction to the side of the palm. Abduction, bring it away from the palm, perpendicular to the palm. This is abduction. Okay, I apologize by that. Extension, you bring it away from the palm in the same plane. Flexion, you bring the thumb to the sides of the fingers. Oppositions, you make contact between the pad of fat of your thumb with the pads of the other fingers. This is opposition. Okay, and circumduction is the sum of all these movements. So remember, abduction involves moving the thumb away in a perpendicular axis to that of the plane of the thumb, while extension is putting the thumb away in the same plane of the palm of the hand. Okay, the metacarpophalangeal joints between the heads of the metacarpals and the bases of the proximal phalanges. It's synovial of the condylar type that has flexion, extension, abduction, and adduction. The circumduction is the sum of these movements. The capsules enforced by palmar ligament and radial ulnar or medial and lateral collateral ligaments. Okay. The deep transverse metacarpal ligament, the one we talked about earlier, joins the metacarpophalangeal joints together. The deep transverse metacarpal ligament. The superficial transverse metacarpal ligament is in the whips, skin whips between the fingers. The deep transverse metacarpal ligament is not between the thumb and index. It's deficient there to allow for free movement of the thumb. The interphalangeal joints, synovial hinge joints, simple flexion and extension. Capsules are enforced by medial and lateral collateral ligaments and palmar ligaments. Now, fracture of scaphoid, a common type of wrist fractures. The blood supply, the problem here, because the blood supply of scaphoid is by a branch of radial that enters from the distal end. So in fractures, there is a proximal avascular necrosis of the scaphoid. There's another type of avascular necrosis called Kienbock's disease. It's avascular necrosis of the lunate bone. The common fracture of the wrist is the Cooley's fracture, the one you see here. See this dinner fork deformity? It's a fracture involving the distal ends of the radius and with posterior displacement of the distal end of the radius. This is the dinner fork deformity in Cooley's fracture. Fascia and retinacula of the hand. The superficial fascia on the palm is the skin is adherent to the deep fascia because of ligaments traversing the superficial fascia to the palmar aponeurosis, and ligaments increase in furrows in the hand, and the fat forms a cushion pad, especially in the fingers. You see the pads in the fingers. The deep fascia forms flexor and extensor retinacula, synovial sheath of the flexor tendons, and the palmar aponeurosis. We'll study it soon. The flexor retinaculum turns the carpal concavity into a tunnel, as you can see here, attaches to tubercles of the scaphoid and trapezium laterally and pisiform and hamate medially. It splits to enclose the flexor carpi radialis muscle. This is a cut section of the carpal tunnel. 8 tendons of flexor digitorum superficialis and profundus are stacked in the canal in the way that, remember, the superficialis in 2 sheets. The middle 2 for the middle and ring fingers, and the lower 2 for the index and little fingers. But the for flexor digitorum profundus are arranged in a linear manner, flat manner. Tendon of flexor pollicis longus lateral to flexor muscles, as you can see here. Okay, tendon of flexor pollicis longus. The median nerve in between them and in the canal, and we have a syndrome called the carpal tunnel syndrome. It's experienced more in pregnancy in females, where there's compression of the median nerve. Now the trick here is that, is the palm affected? Sensation on the palm affected? Well, sensation, if there is something wrong, something compressing the nerve or injury of the nerve inside the carpal tunnel, the nerve already gave the palmar cutaneous branch before the canal, so the sensations on the palm will be spared. Only the sensations on the lateral 3.5 fingers will be affected. Got that? And of course the motor supply for the thinner muscles. The thinner muscles leads to wasting of thinner muscles and making what's so-called the ape hand. Okay, if there's injury to, it's not in the carpal tunnel syndrome, of course, it's in the, if there is injury, complete injury of the median nerve. Okay, once the pressure is released, everything goes back to normal in the carpal tunnel syndrome. The extensor retinaculum from the anterior border of the radius to the medial side to the triquetrum and pisiform bones, so it's oblique. That why it's oblique, because to make it get taught in pronation. Gets taught in pronation. When you operate on something with your hands, you are using your pronation. And for more precise movements, you need more, compression of the tendons of the extensors, make their action is more accurate. The fibrous flexor sheaths for flexor tendons are, as we discussed earlier, they are alternating cross and horizontal connective tissue bands, and there are synovial sheaths for tendons with vincula. Remember the vincula longa and breva, the synovial brain extensions that carry minute blood vessels to the tendons. Okay. For the synovial sheaths or bursa of the hand, we have the radial bursa, which is the sheath around the tendon of flexor pollicis longus, extends 2.5 centimeters proximal to the wrist joint. And the ulnar bursa, the one you see here, around the long flexor tendons, and it's interrupted in the middle in the metacarpal level, not continuous to the index and middle and little and ring fingers, but it's continuous all the way to the little finger. Okay, why do we care about that? Because this is a plane for infection. So if there is infection in the pulse space of the middle finger, it will be confined to the middle finger because the synovial sheath is interrupted. But if we have infection in the pulse space of the little finger, this will spread all over to the palm of the hand, and maybe also to the proximal to the wrist, to the forearm. Okay, so this is the radial bursa, and this is the ulnar bursa, and the synovial sheaths of the fibrous flexor sheaths that enclose the long flexor tendons. There was an infection actually common among florists that involves pulse space infection because of the thorns of roses. Now, the palmar aponeurosis, the one you see here, extension of palmaris longus tendon, the plantaris in the lower limb is interrupted to the heel, but here the palmaris longus is continuous as the palmar aponeurosis. It tenses the palmar aponeurosis. It extends to the metacarpophalangeal joints and deep transverse metacarpal ligament, and sends septa perpendicular to the hand, medial to the fifth metacarpal, intermediate to the third metacarpal, and lateral to the first metacarpal. This divides the hand into spaces. We have the mid-carpal space, which is superficial and deep mid-carpal spaces. We have the hypothenar space, medial to it, and we will get to that soon. Okay, these are the spaces I'm talking about. Because of the septa from the palmar aponeurosis, this is the thinner space on the lateral side. This is the mid-palmar space, or the deep mid-palmar space, because this is the superficial mid-palmar space, and we have a hypothenar space. Now, the mid-palmar space between the middle and intermediate septa, divided to superficial and deep. The deep mid-palmar space extends in the forearm to the space of Parona. The space of Parona is the space below or beneath the flexors, the flexor digitorum superficialis and profundus, It's the space below the flexors, the plane below the flexors. Superficial mid-palmar space contains the third through the fifth flexor tendons, and the second through fourth lumbrical, the superficial palmar arch, and the digital vessels and nerves to the third to fifth digits. The deep mid-palmar space, transverse head of adductor pollices and interossei of the third and fourth spaces. Why do we study the spaces? Because they are plain for infections. Last thing about the fascia and osteology of the hand, the pulp space and whip space. This is the pulp of fingers. There are ligaments, that traverse the pad of fat against the phalanges to turn it into multiple fat loculi, so it's fat under pressure. That's why anything that stings here hurts, because the area is under pressure. And sometimes it gets infected, but when infected, the epiphysis of the bone is spared because it receives its blood supply earlier from the artery, before the artery enters the pulp space. The whip space is the whip of skin between the bones, between the fingers, and it contains the bifurcation of the blood vessels, not the nerves. The nerve bifurcates, more proximal, but the blood vessel bifurcates, just proximal to the whip space. That's why be careful if you're draining something here, abscess or something, not to cut the when you incise, not to cut the blood vessels going to the sides of fingers. Okay, so this concludes our talk about the fascia and osteology of the hand. I hope you got the maximum benefit from this lecture, and thank you very much for watching.